Dr. Sakib here with the Swift Podcast.
3, 2, 1.
Here we go!
What's up, everybody? So we're back with another episode of the Swift Podcast. So today I bring on a very special guest. A lot of you guys might know him. Some of you might not know him. Dr. Caleb Burgess, one of the well-known physical therapists in the world, and he has made an abundant impact with you when it comes to rehab exercises, strength and conditioning on his platforms online. So, sir, welcome to the show. It's an absolute honor to have you.
It's an honor to be on. Thanks, man.
Thank you. So how's everything going? Talk to me. Busy day, I'm assuming, right?
Always. Well, I work in clinic, and then actually today's my day where I'm doing like majority of video calls with online clients.
Okay.
So it's kind of like my online business day to get as much stuff as I can done. But I still have my 6-month-old that's trying to sleep upstairs. We're actually doing nap training right now.
Okay.
So I'm not talking very loud. That's because I'm trying not to wake him up, but I think my headphones are picking this up decently well. So that's good.
You're good, man. I had a 6-year-old will keep you up a bit too. So
Yeah.
there's a lot of topics that I feel like you and I can talk about, and a lot of it like with your background and so forth and some of my background. I want to talk to you about your background as like first OCS and why you kind of pursue that. So I'm currently in a residency. I'm wrapping up in actually 3 weeks.
Nice.
Then I take my board exam. So a little nervous about that, but what made you go there? So your CSCS, which I have that, and then I went OCS. I was between that. So what made you pursue that for yourself?
Well, it wasn't even about the OCS. It was about doing the residency and becoming a better clinician. And what's funny, and this is kind of I go on a lot of tangents. I apologize, but maybe that's a good thing.
That's a good thing.
I know some therapists that have told me that they were almost told that if they knew their stuff, they didn't need to do a residency because that was for people that didn't really have a firm grasp on what they were doing as a clinician. But I viewed it as like, hey, if I want to specialize in something and be really good and be the best I can at this thing, I need to push the limits and really get as good as I can with mentors and like heavy education in that field. So for me, it wasn't even about the OCS. It was just more like I wanted to get that extra experience. I wanted to get grilled by my mentors. I wanted to get that one-on-one time with them, challenge myself. And then the OCS was kind of just like a cherry on top to go like, okay, hey, I put in the work, and it's nice to be rewarded for that. And people are aware of what you know. Yeah. So really it was just because I love orthopedics. I love sports, physical therapy, all that kind of stuff. And I didn't really just want to work with athletes. That's what I originally wanted to do when I got into school, but I wanted to work with everyday people too. I think that's kind of cool. And you see like the most complex cases usually with those type of people, not people that are in the sports. The sports stuff is usually pretty straightforward, to be honest.
Yeah.
It's just, we can just do more fun stuff. But you use your brain a lot more with the general population orthopedic.
Yeah. Dude, right on, because I was in the same boat, right? I spent some time in Exos with Florida, and I was like, I don't want to just work with strictly athletes. I graduated, and then I was in the clinic, and I'm like, I could be doing more, learning more. And I went back for my residency. So I'm in Arcadia. Where did you take your residency at? What program?
Oh, you're in Arcadia. I'm in Chino, so we're not that far away.
Oh, okay.
Yeah, so I did the Kaiser Permanente, Southern California orthopedic residency.
Cool.
And we were kind of pushed because I went to Azusa Pacific.
Okay.
And we were pushed, not really pushed, but a lot of our teachers and faculty are involved in that residency as mentors, and a lot of them have their OCS and their I don't know if you know the FAAO MPT. So the funny thing about that is I could have that one too and SCS, but I just never actually applied for it. I went through all the training and the fellowship to get that, but I never applied because I was just like, I don't really know if I need this yet.
Yeah.
And it's just too many letters. It gets crazy.
Yeah, I agree with you. And I was at the same boat, right? I was debating SCS, OCS. I went with OCS just because of the versatility and like the learning aspect, right? You're learning so much more manually and like the hands-on skills, but just enhancing my ability to treat patients and like empower with movement. And to kind of piggyback that, I was a strength and conditioning coach for 10 years before I went back to get my DPT license.
Wow, cool.
And so now I'm trying to like bridge the gap, sort of like what you're doing. So let's talk in terms of strength and conditioning and the relationship to physical therapy. And I felt like for me, as I was a trainer, I used to see a lot of like clients that, you know, they're coming from PT, and I was like, I don't know what you did, and you're here and you had these issues. And I was not educated enough in that process, but I feel like there was a missing gap. Right. There was a missing link between like strength and conditioning and physical therapy. And the patients are left in the burner. Your thoughts on that?
Yeah, it's weird. Part of me wants to like be upset sometimes with what we know as strict physical therapists, but then part of me thinks like, it's not a lot of people's fault.
Yeah.
Because if you learn what you learned in school, and then you're seeing people at these a lot lower levels, and you don't see many higher level athletes or individuals who do recreational activities that require a lot more strength conditioning, like higher level strength conditioning stuff. I mean, you're not exposed to it, and if you're doing the same thing over and over and over again, it's like a lot of times these therapists, they don't have any reason, or it's not their drive to learn this stuff. But then what happens is every once in a while, one of those people will leak through the cracks and be with that physical therapist. And then that therapist gets to a point where they're like, well, these exercises normally work with my sedentary 70-year-old, but not with this 20 to 30 to 40-year-old like triathlete. It's like so I don't know. I can't blame therapists that aren't doing a great job with that. But at the same time, I feel like there should be a little bit more, well, I guess a lot of it more, education as a whole, starting in school.
Absolutely.
For those principles. And I feel like, I think we got it, but it wasn't emphasized to the amount that it should have been, maybe.
I feel like we're getting it more in the residency, though. I will say that compared to what I did in like the DPT program, residency definitely gave us more for it. So currently right now, you're OCS and SCS, you're working with a lot of patients. Do you find that it's a lot easier to kind of mesh everything together for yourself? Like you're seeing some high level athletes as well as some lower levels.
Oh yeah.
Right.
For sure. And it's, and that's what's cool. And that's what I wanted to do. I wanted to be able to see that 70-year-old grandmother who can't stand up off the toilet, but I also wanted to be able, and who's having trouble walking or had a stroke or something, even though it's technically neuro stuff, but same umbrella. But then I also wanted to see a young kid who is trying to come back from a big injury, like an ACL injury and stuff. And it's rewarding in two different ways. And to be able to like know enough on each end of the spectrum to help both people is really cool. I wouldn't want to just work with one of those populations, but I like to work with both.
Absolutely. I feel like we took the same path. I'm serious. Like I really wanted to go specifically just to sports, and then something about it, right? It was just like they were more fine-tuned, but a lot was like, just pamper me. I want to do this, just this manual, just this aspect. And then in the general setting, you get such a challenge. And that's the beauty of why I left training and strength and conditioning for that challenge space, right? Like everyone can get stronger, bigger, faster. But the challenge you have with the PT side is a lot of fun. So I know one of the biggest topics I wanted to cover with you specifically was neck pain. And it's a huge issue going on currently with the pandemic, people working from home and so forth. So let's try and talk about like root causes of neck pain, where people kind of start to derive from, so they can kind of pick up on these things of habits. Like what are typical habits we're seeing in the clinic that are going to lead to these issues?
Yeah, so we can go really deep down the rabbit hole with that as far as like all the contributing factors. But
absolutely.
I feel like some of the most common things that I see are just, like you said, like people who, when we talk about it from just like a biomechanical standpoint, or even like neurological, like just lack of movement throughout the day. So just people that are in the same positions over and over again, repetitively doing the same things and not even realizing it. And a lot of times, I guess, note for clinicians is like, you'll see these people they'll usually say things like, I'm not even doing anything. And then it's just like, what sort of things make this hurt? Well, nothing. It just hurts. It's like, okay, well, how do you spend your day? And then picking up on those habits of like, what are the things that they're doing throughout the day, and get them to show you how they're doing those things. And you'll see these habits of people getting into these either awkward positions or even just positions that don't look that bad, but they're like, oh, I was doing that for 4 hours at a time. So a lot of that has to do with like the desk work and things like that. But like in young kids, you'll hear things where like they're in bed and they have like 4 pillows under their neck and they're watching TV and it's like cranking their neck forward, or they're just sitting in bed like reading, and these like their whole body's in the slumped position for hours and hours and hours. And then you have the other end, and again, you can stop me if I start to go too deep into this, but the other end are the people that are reading so many things online and then they're like overly like hyper focused on their posture. So they'll erect all day and they like don't allow themselves to relax or just move. They're just always like, I need to stay up, get my shoulders back. Like they're just like, number one, they're so hyper focused on it. That's not helping things, but then they're not allowing their spine to move forward in like a slouch position. So I would say that probably happens less often, but when it does, it's interesting. And those people, you kind of have to explain things a lot more about like why they don't need to do that as much, and just get more movement into it today.
I love how you said that, because I feel like at times we as therapists get so stuck on the perfect posture, and we cue for posture, and we put that in the patient's mindset. And then they're like, well, I'm going to walk like this from now on. We don't walk like that ever. Right. And it's just like, so I love that good education component. And in terms of like acute neck pain, if someone's suffering from acute neck pain, what are your like go-to education tools? We're not going to talk movements. I feel like it's just so dependent on different persons, but like education wise, what are your cues for those people?
Yeah, so acute neck pain, meaning like they just strained it or it's hard to move it in any direction. A lot of times, some simple things that people can do are just unload their arms, their shoulders, because you think about all the muscles that attach from the like scapula to the spine and the neck, and just that weight that's normally not a big deal can be an issue. Just pulling down and just unloading them, having them cross their arms or place them up on pillows or things like that can be really helpful. And then, to be honest, a lot of times, and this is not like a sexy answer, and it's kind of the same way for back pain sometimes, is like just having people lay down more throughout the day and just like have their neck just resting on something, just laying down can be huge, especially in those really early phases. And then the other thing is you want to try to talk down like the scariness factor of it. So some people are so afraid to move their neck because it hurts so much to move in any direction, and just letting them know like, hey, you can move within your tolerable range of motion. A word that I use like probably like 50 times a day is the word tolerable, and helping people understand like, hey, even though it hurts to maybe turn your head in either direction or look up or look down, if it's tolerable to you, and it's not, and when you do it, your pain isn't like spiked for hours and hours afterwards, then it's okay to explore those ranges of motion, and every day maybe do a little bit more if possible. Don't force it through extreme pain, but if it's uncomfortable, that's okay. Uncomfortable is okay, but usually like a lot of pain is not okay. I mean, obviously there's some variation there, but just helping them understand that that's not necessarily damaging things more can be helpful.
And I like that, right? It's like more education process. And then what about tissue irritation? What are your thoughts about like if someone's got an acute issue, like a strain, are we touching the tissue, or are you kind of letting it calm down itself? I tend to have patients be like, hey, if it's upset, don't be poking at it, right? Let it be, let it alone. What are your thoughts on that? I feel like everyone has such a different opinion on those aspects, especially with acute injuries, right?
Are you talking about like telling them what to do for it themselves? You're talking about like how would I treat it when they came in?
No, I would say what they would do themselves. I always find like when patients come in, they're like, hey, this hurts, and they keep touching it. Like, well, if it hurt, leave it alone, right? Don't touch it.
So that's funny. So yeah, I guess a general answer on that is like a lot of times patients are always asking like massage, or do I need someone to work this out? And like you said, like sometimes stuff's just pissed off for a reason. And if you think about it, like really, like think about us like hundreds of years ago, before we had like all this training on pain and musculoskeletal stuff. Like what would happen in the past? Would you really be poking and prodding on things, or would you just go, let me just leave that area alone for a while because it's telling me it hurts? You know, like before we knew about like, or we had these theories about what massage or manual therapy and stuff, that's like people would probably just go, well, that area hurts, I'm just gonna leave that alone and carry on doing other things I need to do in my life. And so that constant poking and prodding actually, like you said, can make it more sensitive because you're just poking on something that really doesn't want to be poked on. And sometimes, I mean, if I do any, like, let's say manual hands-on stuff, it's usually only if they're so afraid to move themselves and I can't get them to do things on their own that I will lightly put my hands around their neck, give them that feeling of that like light, warm, comforting touch, and there'll be like guide some movement, but I'm not going in there and like digging my fingers in there and that kind of stuff, especially in those acute phases.
And I remember that as early on in my career, we used to do a lot of that, right? I was like, oh, let me just touch it for you. Get to the residency. She's like, well, I was like, no, we're going to let it rest. And more so like passive range of motion and just active range of motion on them is enough for them to calm things down and so forth. And then the next hot topic we get is modalities. What are your thoughts on in terms of modalities for acute neck pain and which one would be the most recommended?
Yeah,
in a sense.
I think in acute phases of a lot of injuries, I think modalities can be super important as long as your narrative is on point with them. I think a lot of times people will say negative things. No, they don't know that it's negative, but they're saying these things about modalities that make people think that they need to be doing them. And they're like this magic cure to their issue. When really, if I just tell them, hey, time, slowly getting back to your movement and respecting your pain, but not fearing it. Those are like the biggest things I need to be aware of, and then educating them throughout the process. But then going, you know what? It hurts a lot. It's okay if you put an ice pack on it. You can put a heat pack on it. And really, you let people choose. I mean, from what I've seen with more like acute neck pain, it seems like people tend to like the ice, but at the same time, when they had it for like longer periods, they tend to like the heat more. But that's just like anecdotal. I mean, it really depends on the person, and just letting them know like, hey, either one works. That's what I would do if I really was having trouble. Sometimes, I mean, this is not like a sexy opinion, but like putting a TENS unit on sometimes can be helpful too. And just telling them like, hey, might make it feel a little bit better while we do this. Let's try some movement with it. You know, I don't do that often, but every once in a while, I think it can be helpful. Or if they ask about it, I'm going to tell them like, hey, this is not like powering up your neck and like fixing things to do this electrical currents. It's just helping you feel a little bit better so you can move and your body can heal itself.
Yeah. And I think that's one of the things my mentors have taught me in the residency program is essentially like, if your patient feels good with it, do it. Right. If they're feeling better, they're going to buy into you and kind of essentially have it, and then put your perspective later on with that. And a lot of times I think with PT, what I'm finding is I think people look at us as like the healing power, but I'm like, no, we're just setting you up to heal. We're setting up for these movement patterns, setting up for success. And that part of it falls in for success, right? If you get them to relax a little bit more, it helps out in a sense. But acute injuries are very like interesting in a sense, right? Like I just find that
it can be awkward at times. It can be awkward at times with the patient, because if they're viewing you as this person, like I am coming here for you to heal me. And then I'm sitting there going, honestly, I don't need to do too much. You just need to like give it time. and you know, you have a cold pack at home, or you have frozen peas at home, or you can do these same exercises without me. And people look at you kind of like, what's the point of me coming in? And you're like, and in our minds, we're going like, I don't think you understand how powerful the things I just told you were. If you would have got bad information somewhere else in the rabbit hole, you could have gone down. But now that you know, you're probably going to get better in a few weeks or a month or two, right? I'm putting you on this path that you actually will improve, rather than having like this persistent pain for months and months and months. That's so valuable. But they might look at it as like, this is a waste of my time. You didn't like fix me with your hands in a visit or a couple of visits. And that can be challenging at times. And a lot of that has to do with marketing that's out there online and things that they learn online. And they think, like you said, like we're the healers rather than the facilitators of healing.
And I think it comes down to, as you like just hearing what you said, is like kind of empowering the patient to be more independent with themselves, right? Because they're not coming to us for the rest of their life. At some point, your insurance is cutting you off, and that's it. And then what do we do, right? So it's education. That's a great tip for the young clinicians out there that are leaving PT school now to graduate, that are going to be in the industry soon. I've learned that the hard way. Like I initially did not care about visits, right? I was just cranking people in, let's get you going. And then the first time I learned, I had a post-op knee, and I was like, what do you mean he's out of visits? He's post-op. He's a month in. He's like, what are you doing? And that's when you learn of like independence. So it's a great, I mean, I learned the hard way, right? And I'm telling that to everyone listening today. Insurances are torture at times. It's a big process.
I actually, and I will tell you straight up, the reason why I do what I do in my side business online, where people just pay out of pocket, is 'cause I don't want to deal with insurance. I wanted to set them up for success. I mean, it does cost them money, but it's kind of off tangent a little bit, but there's a quote that says like, if people pay, they pay attention. So we all have those patients that come in who their insurance, like, was just low copay, and they're just kind of like, whatever. And they're not really putting in the consistency. They're not compliant. But when someone has to pay money and put money down and know, like, shoot, I got to put in the work, they're going to put in the work. Number one. But then the other thing is just not having to deal with insurance saying, oh, you only have 6 visits. And we're like, this person needs to be seen for a lot longer for their issue, right? And just not having that restriction is huge. And then the other thing, like I mentioned, like the residency that I went through and the fellowship that I went through at Kaiser, some people aren't big fans of Kaiser, and I can understand why some of there's negatives on there. But what I like about it is there's not like a cap on visits. I can see somebody as long as I want to see them, as long as the doctor's cool with it. And I'm talking to the physician about like continuing their plan of care. So people will come in from like maybe outside therapy places and go, oh, like, how many visits do I have left? I'm like, we have as many visits as we need to get you better. So there's positives and negatives to the system. But what I like about it sometimes is I can see somebody for 1 or 2 visits and go, that's all you need. Boom, we're done. And rather than having to maybe draw something out for 6 to 8 weeks or whatever, 6 to 12 visits. I don't even know what the normal is anymore. Instead of having to like kind of keep them coming in and make them feel like they're still like injured, when in actuality they could have been maybe good in 2 visits and they're like on their way and they're like, I don't really need physical therapy. I'm good. Like sometimes coming in too often can be an issue. Yeah. And then also, like you said, like if they getting cut off, it's nice to be able to continue things
absolutely
forward. So that's kind of a nice thing with that system that I like.
Especially have like your own background, right? I feel like and for me, it's now finding the balance between like strength and conditioning and physical therapy. But like, I feel like once they're at a point of healing and things are responding better, I want to put the strength and conditioning side into it. I want to test your measures. I want to put you in that basis. So at least you have the opportunity now to like excel that, right?
Yeah. Especially if they have those goals. It's like you maybe help them get better from the initial injury, or if they had surgery, you're trying to help them recover from the surgery, but then to actually get back to like playing their sport and stuff, and not just getting like improving their like strength deficits or mobility deficits, but getting them back to like, okay, like how do we have you handle jumping and running and cutting? Like that takes a lot longer to get there from a physical and psychological standpoint.
Absolutely. And I think as I'm listening to you speak, and this is good advice for those of you who listened to the episode, is Caleb is an educator before he's a clinician. And if you really educate and empower your patients to being optimally for success, and I think you said it earlier in the conversation about like the pain part, right? Like, yes, you're in pain, but you don't really need me for more than 1 or 2 visits because you're empowering them for those movements. I think that's the missing link. And I think I've learned that more in the residency than again in PT school, by really truly educating the clients and educating the patients of like pain perception. And we just spent the last 2 weeks with our residency of like the psychosocial aspect of it, right? Talking to them about their pain, listening to what they're saying, and then opening up to the environment. What else can be factors of these stressors? Did you guys dive into that with your residency program at all?
Oh, and crazy. We actually had, in my fellowship, my second year we had Lorimer Mosley fly out, and we had like, we had like 8 of us, and like we spent the day with him for a couple of days, went to lunch, and like, he's a hilarious dude, but like, yeah, we went deep into the pain stuff. So all that stuff is so important, all those contributing factors and things going on in their life that is more than just how are you moving, what tissues are you stressing. That's only part of it. But a lot of times people think that's the only part of it, and that can cause issues if they don't recognize the other contributing factors in their life.
How are you educating on that? How are you educating on the external resources that like our external environment that's affecting the patient's pain? And if you feel like, we have some patients, like I follow a lot of work with like Dr. Andrea Lowry and like the outside alarm system, in a sense, not shutting off.
Yeah.
And there's that. So like, I'm still learning on the education process, right? I always find it's like a hard part. So for those of the young clinicians out there, how would you give them like a tip for them on like education on that aspect?
Yeah, I think if you would ask me this 5, 6, 7 years ago, I would have given you like here's how you do it. But to be honest, it's, and you've probably seen this too, is like everybody has their own stuff they're dealing with. Everybody understands things differently. Different metaphors and analogies work for different people, and some people will go completely over their head. So unfortunately, and this is what makes it super difficult, even if you've been treating people for 20, 30 years, is like you have to really understand that person really well before you can really dive in deep with this stuff. So on the first visit, it's really tough.
Yeah.
Because sometimes you're kind of like shooting at a target with a blindfold on. Like you think you know what might hit home with them if you feel like there's some of these issues that they're dealing with that are outside of like a straight up like your knee hurts when you squat or whatever. Yeah. Like all the psychosocial stuff. So you try to do your best, but I think when those conversations really get good and they get more effective is when you've been working with them for a while and you get to know them better and you understand their humor, you understand their fears, you understand things going on in their life, and they're comfortable opening up to you about this stuff. Because a lot of people day one are not going to open up to you about this stuff. They're going to be very guarded and they're going to think, why would you need to know as my physical therapist? So to get them comfortable and to become their friend, not like in like a sleazy manipulative way, but actually like want to get to know them better, understand them better, they will start to unload things more that is very obvious to you as a clinician that, oh, this is stuff we need to address. I don't know if I'm answering your question. I think maybe just
you're good.
Scratching the surface as to how it might be different for different people. But as far as like educating them, I think using different metaphors, using different analogies, and there's so many of them. You can even make stuff up that you haven't read online or in a book, but things that make sense to them, and basically making them understand I think most people need to understand that pain is not this like thing that happens to you, but it's your body's like way to try to protect you. It's your output from our body. And then always prefacing that with people understanding that I'm not saying it's coming from your head, and letting them know if you have pain, it's real. It doesn't matter what the main contributing factors are. It is real. You could have really strong emotions or a traumatic experience that has nothing to do with physical injury. And if you have pain, it doesn't mean you're crazy. That's just your body's physical response to something going on in your life that makes it think that you need protection or it needs to warn you about something. And sometimes that can be like fear or anxiety, but sometimes that can actually manifest as pain.
Yep.
And then just kind of, you can go down the, like, again, I keep saying the rabbit hole. There's so many things you can talk about here, but like, I'll tell people too, like sometimes you could have had an injury 10 years ago and it was a really bad injury. And it was really traumatic and it really affected your life. And you were good for a long time, but then like it came out of the blue a couple of years ago and it stayed with you ever since. And it's really bad. And it's not necessarily because of that injury you're still injured. It's because your body, sometimes I feel like your body chooses where it's going to manifest pain from other areas. So you could have another traumatic, maybe you're in an abusive relationship or something, and it started a year or two ago or something. And all of a sudden your back pain that you injured 10 years ago is way worse. You're not doing anything to your back to make it worse, but it's almost like your body has this physical representation of pain, and it's going to choose the area that's kind of your brain remembers was a really painful area to manifest that at, versus your shoulder if you never had a shoulder issue. That isn't always that way, but a lot of times that does happen because there's these areas your brain kind of remembers, hey, this area is a little bit more sensitive because I know I've had an injury before, but I'm going to manifest this pain that has nothing to do with that injury in that area. But then that screws with people's minds because they're like, well, now my back is deteriorating or whatever. So there's so many things like that. And that's only one of like thousands of examples. But I think just understanding and making your story or the way you explain things fit the patient's life very specifically to them, and de-threatening what pain means and helping them understand that you can have pain without damage is super important. And then having them try to look inside themselves and their life and understand like what are all the things that you can do that tend to make your pain feel better, other than just exercise, things that make you feel good, people you're around, all that kind of stuff. And what are all the things in your life that contribute to just making things just feel worse overall. Like, and people never really usually look at it that way, but once they start to look at it that way and understand what you're saying, you'll find a lot more things that you can work on together.
Absolutely. It kind of comes down to the clinician taking the time to understand and listen to the patient and talk to the patient about these topics. And as uncomfortable as those conversations are, you got to have those conversations. With that, folks, we're going to take a quick break and we'll be right back with you. So we're back with Dr. Caleb, who's been nothing but an abundance of joy to talk to and just a wealth of knowledge. And not knowing him as well as a lot of people do, I just feel like education in his life is a key component of his life and how he is speaking to us and what he's empowering. We didn't talk movements. We didn't talk specifics. We talked about empowering you through education. With that, we talked for a break. So the floor is yours. Let's hear your 3 pieces of advice for our young clinicians, young professionals out there.
Well, as it relates to education, correct? And how it
yes.
relates.
Absolutely.
Yeah. And so basically, I mean, for myself, I feel like educating yourself, if you want to get into a specific field of physical therapy, because for those of you that aren't clinicians that are listening to this, physical therapy has different like subspecialties, as we talked about at the kind of the beginning. So if you really want to work on a specific area, I think it's well worth your time to invest the time and finances and stress to really focus on challenging yourself and not be afraid. I guess tip number 1 would be like embrace failure. And I know that sounds kind of cheesy because a lot of people say that, but like really like embrace failing. Sorry about my son in the background, you might hear him.
Okay.
Just embrace the fact that like when you come out of school and you don't really know how to get all this information that you've learned to fit, and things aren't very cookie cutter, and you're expecting patient presentations to be easy. Finding somebody to mentor you or joining like a residency program or something like that to challenge yourself and not treat it like you're trying to get a good grade and you're trying to pass and get an A every time you're with a patient, which is really hard not to do, especially when you're coming straight out of school. But like embracing it as like, hey, I'm ready to screw up. I'm ready to not do the best job. And I have this mentor who's been doing this for however many years and who's gone through what I'm going through now and can basically, in a constructive way, pick me apart so that they can like identify my weaknesses and my flaws. And that will constantly be something that I can add to my learning. So rather than just learning random stuff and not knowing what you need to be working on, you have somebody there and a program that you're going through that is like telling you like, this is what you need to work on. Here's your weaknesses. Here's the things that you need to clean up. Here's the things that you need to improve. And then just diving into really becoming a specialist in that area by getting education that is focusing on that sort of specialty, I think is super important. So I think I'm not putting them into 3 different tips. I'm more just like telling you all the things that I feel like would be helpful there.
Absolutely.
I think that's one of the main ones. And then not being stagnant. So don't just rely on, okay, I did this program. Like even if you finished with doing something like advanced education like that, continuing to look at the research, continuing to follow other people who put out good content online that sometimes will summarize the information from research, or challenging your biases. So never being stuck on a specific bias, because in physical therapy and fitness and strength conditioning, it's a lot of it isn't, as hard as it is to say this, a lot of it doesn't have super strong evidence behind it. Yeah. We're still kind of in our infancy as far as how research goes. So if your biases or your beliefs change in a few years, not being so focused on this being like a black and white thing, and knowing that like, okay, this is something that I was telling all my patients and I was teaching them, but you know what? There's a lot more research that's come out now that shows that that probably wasn't the best advice, and being okay with that and embracing that and actually taking that as like a positive thing. Like, hey, things aren't all set in stone. It's not like human anatomy where it's like not going to ever change. Like that's not going to change really, unless it's like maybe thousands of years in the future. But just knowing that, like, hey, a lot of the things that we do for exercise or for treatment, like that stuff can change, and that's okay. Even if you learn something different when you were in school or whatever, you feel like this is the best way to do things. Maybe it won't be in 10 years, and embracing that, I think, is important.
Absolutely. I think it comes down to is education is the most powerful tool we have, but applying that education is going to be even more powerful. When you listen to this stuff and everything he's talked about, it comes down to education. And we're both living examples. I'm going through the process. I have more certs and courses that I want to take just to better myself, because I think it overall does carry to that. And I've had a lot of guests here that we've talked about, like having the person where I'm assuming where he was 10 years ago to where he's today, a completely different person education wise. And that's what we're trying to empower with that. So thank you for your advice. Thank you for your tips. And I thank you for coming on today's show. I truly appreciate it. It was a true honor to have you. Been following your work for a while, and I hope to have you on again soon.
Oh yeah, for sure. It was a blast.
Absolutely.
Thanks, man.
Thank you. And with that, folks, this concludes today's episode. We'll see you guys next time.